Thank you very much, and I'd like to again thank Dr. Ranawat and The Rock for inviting me. This is a pretty exciting place, and it's my first visit to India, and it's clearly, I'm not in Kansas anymore, that's for sure. My task today is to discuss new trends in infection treatment, and a lot of this is the work that our Chief of Infectious Disease at Special Surgery, Barry Browse, has put together, and I'd like to share these thoughts with you. There's two crucial aspects of this particular presentation that I'd really like to emphasize. The first of which is the trends in antibiotic prophylaxis. These, again, should be very practical. And the other are trends in the treatment of an established infection. So in terms of the current state of antibiotic prophylaxis, there's initially three performance measures that I think, certainly in the United States, that we pay particular attention to. The first is initiation of the antimicrobial therapy within 1 hour prior to the surgical incision. And again, there's a lot of data to support that. The second is the appropriate choice of an antibacterial, antimicrobial agent, and the third is antibiotic therapy discontinued after 24 hours. And note that the appropriate dose, if you're using, for example, a first-generation cephalosporin, which again might be 2 grams, is weight-related, greater than 80 kilograms. Again, you want to certainly increase that. And the second is that if the surgical procedure is extended beyond a 2-hour limit, you want to go ahead and give a second dose of the antibiotics. The workhorse is going to be first-generation cephalosporins. If there's an established penicillin allergy, certainly we go ahead and do some skin testing to verify that, at which point we'll go ahead and use vancomycin as an agent of choice. The other option may be the use of clindamycin. Consider changing your routine prophylactic regimen from the first-generation cephalosporins, i.e. cefazolin, to vancomycin only if your infection rate in your institution for joint replacement has certainly and been documented to increase over a period of time and a sustained period of time. Again, if your infection rate is essentially doubled, it's greater than 2% on a monthly basis for a few months, it's when you may want to go ahead and consider going from cefazolin to vancomycin. Again, our biggest concern is the development within your own institution of resistant antibacterial agents such as methicillin-resistant Staph aureus. Now, screening for MRSA, I can tell you right now that the data is certainly not clear on this. In some institutions in the States, people are going to nasal swabbing, topical Bactroban to decrease the carrier state. Again, this is controversial, but again, if you have an outbreak of MRSA in your own institution, it may be something that you want to consider. In terms of the infected knee, I think we've had 2 or 3 excellent talks speaking about that. It's devastating, obviously, to the patient, to the institution. It is a money loser. It costs a lot of money to take care of these patients, as well as to the surgeon itself. The key is don't bury your head in the sand. Take a step back and think, plan, and execute when you're encountering this. The principles, again, identify your organism, thorough debridement, which has been outlined. Successful wound healing is certainly paramount. Selecting appropriate antibiotic therapy, and then again, the appropriate reconstruction. The diagnosis that we know, and I think this has been gone over a little bit, there's lots of different ways to look at this and to diagnose occult periprosthetic joint infections, and you can see in terms of sensitivity and specificities, these range from basically plain x-rays, which are of limited value, to essentially the gold standards, those being joint aspiration as well as cell count. And I'd like to call your attention to the use of the cell count. It's cheap, it's inexpensive. You can get some fluid from a suspected joint. You can send it in a tube. They can run a CBC for you. And if you're getting back cell counts greater in excess of about 1,500 to 2,500, then certainly your index of suspicion should be high. This is an example of an aspiration arthrogram. Joint aspiration, again, for the suspected patient that has residual pain right here. If they've been on antibiotics, stop those antibiotics for anywhere from 2 to 6 weeks. Aspirate. If your index of suspicion is high, repeat aspiration. And just remember, there are certain bacteria that are sort of notorious for being very fastidious in terms of their growth. These include the staph, coagulus negative staph, the Corynebacterium, and the like. So just remember to keep that in mind. Essentially, again, consider tissue diagnosis sometimes. This is a reasonable thing to do as well, where you can send off histology, pros and sections, and these are some of the things. In terms of looking at how you're treating your patients and along these particular lines, there's three essential tests that I think many of us are familiar with, but I'd just like to spend a moment going over this. In terms of quantifying your susceptibility of your organism, first is an MIC, which is an inhibition of the bacteria that you're growing out from the individual patient. This is also supplemented with something that's called an MBC, which is bactericidal. Now just remember, this is the patient's own bacteria that's put on an agar dish with known concentrations of an antibiotic in each one of the little plates that the patients will have. The controversy, again, is that these essentially are not necessarily going to be predictive of what your own individual patient and how that patient is going to metabolize the antibiotics and how they are in vivo going to eradicate the infection. Now, if you ever read any of the stuff that's come out from special surgery at our place, we have for years used serum bactericidal testing, where again what we do is we take aliquots of the patient's own sera, spin it down, and run it against their own bacteria. It's very labor intensive, it's very expensive, but it's certainly been highly predictive in terms of our success rate. If we've been able to get serum post-peak levels, SPTs of 1 to 8, our eradication of infection is upwards of about 95% for hip replacements and about 92% for the knees. So we find that this is a very useful and good approach. It's worked well in our hands. So whether it gets adapted universally, as I say, it's a little labor intensive, and this is just some of the data that we've been able to demonstrate. In terms of microbial resistance, we see that there's emerging patterns now with MRSA as well as the VRSA, and this is becoming a significant problem, as certainly not only in the States as well as I think worldwide. And you can see that the success rate for the treatments of these resistant organisms is certainly been compromised as there's been this emerging pattern of microbial resistance right here. To reduce some of these, again, we have been using, again, third-generation cephalosporins in terms of prophylactic measures, also the use of vancomycin as well as some of the fluoroquinones, as you can see. Once we've got established infection, just a couple of quick points here. The antibiotic-loaded PMA cement, again, you're always going to use this in synergy, tobramycin, gentamicin, certainly less optimal for the enterococci. Vancomycin alone should be rarely indicated. Again, what you want to do is essentially use vancomycin in conjunction with one of the aminoglycosides. It improves the elution properties as well as improved potency for antibiotics. There's been new antimicrobial agents that have come out. I think you'll be seeing more about this in the literature in terms of the treatment for established established periprosthetic joint infection. Again, combination therapy is going to be the key. Post-operatively, it's very common at our institution. We'll be using intravenous antibiotics in conjunction with rifampin as part of a combined therapy, and this seems to really support in terms of our success rate. So again, combination systemic therapy using, again, vancomycin and gentamicin for our staph, our strep, and our enterococci. For our drug-resistant organisms, again, we've been using imipenem as well as the third-generation cephalosporins, and as you can see with the use of rifampin, linezolid, as well as some of these other agents against the emerging resistant organisms. So in summary, I think it's key to identify what your organism is, what the susceptibility is. If you have access to use some of these serum bactericidal titers, these SBTs that I've mentioned right here, I think it is predictive of success. And again, be on the lookout for emerging resistance within your own hospital. Thank you very much.